If a man experiences, a physical roadblock to intimacy, his doctor has dozens of FDA-approved, highly targeted treatments to offer him.
Right, there's a whole catalog of options.
Exactly. I mean, we are all familiar with the little blue pills that directly address the neurovascular system, but if a woman experiences the exact same physical
Yeah, if
roadblocks,
her body is no longer responding the way it used to,
right, historically, she's just been handed an antidepressant.
which is wild.
It really is. So today we're looking at how a rather controversial injection derived entirely from a patient's own blood is attempting to fix that massive medical double standard.
It's a profound shift, really, in how we approach women's health.
Mm.
Because, for decades, the medical establishment basically treated female sexual dysfunction as a purely psychological issue.
Like it was all in her head.
Exactly.
Right.
While treating male sexual dysfunction as a mechanical one. So the therapies we're unpacking today represent a hard pivot toward repairing the actual physical machinery of female intimacy.
And that is the core of our deep dive today. We are sifting through a truly fascinating stack of sources to figure out if this is, a medical breakthrough or just clever marketing.
Yeah, we've got some great material to work with.
We really do. We're pulling from the American Society of Plastic Surgeons clinical guidelines, digging into peer-reviewed medical journals on the genitourinary syndrome of menopause, and analyzing the actual marketing materials from specialized aesthetic clinics in the UK and internationally.
A pretty wide spectrum of sources.
Yeah. And the mission for us today is singular. We want to unpack exactly what the O-shot is, explore the cellular biology behind it, and answer one fundamental question for you. Can a simple injection actually increase a woman's libido? Okay, let's unpack this.
Well, to even begin answering that question, we really have to establish the sheer scale of the problem the O-shot is trying to solve.
All right.
Before we talk about solutions, we need to understand female sexual dysfunction, or FSD, and the very physical hurdles that actively crush a woman's desire. The data in our medical journal sources is, honestly, it's quite jarring.
Yeah, the numbers really stood out to me.
Right. Roughly 40% of women will experience significant psychological distress related to sexual dysfunction at some point in their lives.
40%.
40%. Yet, despite that massive number, only about 14% will ever actually consult a physician about it.
That gap between the 40% who suffer and the 14% who seek help is, it's heartbreaking.
It really is.
It tells me that women are just accepting this as an inevitable part of aging, or worse, they think it's entirely their own fault.
Right. That it's just a loss of interest.
But the journals paint a starkly different reality. There are severe physical conditions destroying their libido.
Yeah, think about a condition like genitourinary syndrome of menopause, commonly referred to as GSM. This isn't some rare anomaly. It affects approximately 50% of postmenopausal women.
Wow. 50%.
Yeah. And GSM is a direct result of estrogen deficiency, and it causes severe physiological changes. The vaginal epithelium, which is the tissue lining the vaginal wall, literally thins out and atrophies.
Wow.
Natural lubrication plummets. The vaginal pH increases, which then invites chronic infections.
And the sources go beyond just menopause, right? Like they detail lichen sclerosis, which is a chronic skin condition causing painful scarring and tearing in the genital area.
Yeah, that's a major one.
And they also cover dyspareunia, which is basically the umbrella medical term for painful intercourse.
Exactly. When a patient is dealing with micro-tearing of the tissue, severe dryness, and, chronic inflammation, the physical act of intimacy transforms from a source of pleasure into a source of dread.
Right. It becomes something to just endure.
Or avoid entirely.
Which brings me back to that double standard I mentioned earlier. Let's look at the current pharmaceutical solutions. As we noted, men get targeted neurovascular drugs to fix the plumbing, so to speak.
Right. Very localized.
But for women, the primary FDA-approved drug for female sexual dysfunction is a daily pill called flabanserin, and it doesn't do a single thing to the genitalia.
Nothing at all.
It works by altering serotonin and dopamine levels in the brain.
Yeah, it's an entirely systemic neurological approach.
Right.
Flabanserin essentially operates on the assumption that the libido drop is a neurotransmitter imbalance.
Like an antidepressant.
Exactly like an antidepressant. It attempts to stimulate desire centrally in the brain without addressing any of the localized physical pain or tissue dysfunction occurring in the pelvis.
I want you to imagine like driving a high-performance sports car, but the parking brake is permanently stuck.
They're not going anywhere.
Right. You can pump the gas pedal all day long. You can add premium fuel to the engine, which is essentially what altering the brain chemistry is doing. But if that brake is locked, you're just going to cause friction, burning, and severe damage.
That's a great analogy.
If a woman has physical scarring from childbirth or vascular atrophy from menopause, I just don't understand how a brain pill is supposed to fix her libido. I mean, the engine isn't the problem, the brakes are seized.
Yeah, and that is the exact limitation of systemic neurological treatments. It's why so many women abandon them.
Makes sense.
Now, we should note that traditional hormone replacement therapy, utilizing localized vaginal estrogen or systemic testosterone, remains a highly effective gold standard for many women to restore that tissue health.
Right. HRT is huge.
It is. However, a massive portion of the population, like breast cancer survivors with hormone receptor-positive tumors, are strictly contraindicated for estrogen. They literally cannot take it.
Oh, right, because it could feed the cancer.
Exactly. And others simply prefer not to take hormones due to systemic side effects.
So doctors were basically backed into a corner. If brain pills don't fix the tissue and hormones are off the table for millions of women, they had to find a way to heal the physical tissue locally without relying on synthetic drugs. And that brings us to the O shot. They looked inward, literally into the patient's own veins.
Yes. This is where regenerative medicine crosses over from orthopedics and dentistry right into gynecology. The O shot utilizes platelet-rich plasma, or PRP.
Okay, PRP.
Yeah. It is crucial to understand that this isn't a pharmaceutical compound manufactured in a lab. It is an autologous biologic, meaning it's derived 100% from your own body.
Walk me through the actual clinic experience, because based on the aesthetic marketing materials we read, it sounds vaguely vampiric, but surprisingly fast.
It is fast. The procedure typically takes under 45 minutes. You go into the clinic, and the practitioner draws a small amount of blood from your arm, usually just 10 to 20 milliliters.
So identical to a routine blood test.
Exactly. That vial is then placed into a high-speed, dual-spin centrifuge.
I always wondered how that actually isolates the good stuff. Like, how does a centrifuge work for this?
Well, the rapid spinning utilizes centrifugal force to separate the blood components by weight. The heavier red blood cells sink to the bottom, leaving the lighter plasma suspended at the top.
Okay.
And within that plasma is a concentrated layer of platelets. Platelets are the specialized cells responsible for clotting and, more importantly, tissue regeneration. The clinician draws up this highly concentrated, golden-colored serum of your own biological healing factors.
And this is where I need to play devil's advocate for a second, because we're talking about drawing up that serum into a syringe and injecting it. Anatomy is everything here. Where exactly is this going?
Right. Well, the clinical guidelines for the American Society of Plastic Surgeons are very specific about the anatomical targets. The injections are placed in the clitoral corpus cavernosum, near the glands of the clitoris, and into the anterior vaginal wall.
Okay.
What's fascinating here is the medical community's effort to standardize this target.
Oh, right. They want to rename the target area, don't they?
They do, because the concept of the G-spot has always been anatomically nebulous and highly subjective. To create a replicable medical procedure, the ASPS guidelines suggest defining the injection site as the O-spot.
The O spot.
Yeah, they define this unequivocally as the specific anatomical space located most distally between the urethra and the vaginal wall. It just removes all the guesswork.
I hear the medical logic. I really do, but I have to stop you. I know exactly what everyone listening is thinking right now. We are talking about needles in the clitoris, in the anterior vaginal wall.
It sounds intimidating.
It sounds like an absolute localized nightmare. How on earth is this a popular procedure?
Honestly, it's the single most common barrier to entry for patients. But if we look at the clinic protocols across all our sources, the pain management is incredibly robust.
How so?
Practitioners apply a highly potent medical-grade topical numbing cream to the entire area for at least 20 to 30 minutes before any needle comes anywhere near the patient.
But does a topical cream actually numb tissue that deeply?
According to the clinical outcome data, it is remarkably effective. The vast majority of patients rate the pain of the injection as a 2 out of 10.
Only a 2.
Yeah. They describe a sensation of mild pressure or like a strange fullness rather than a sharp, piercing pain. And because the serum is your own blood, there is practically zero risk of an allergic reaction or rejection. Clinics actually advertise zero downtime, claiming patients can resume sexual activity that very same day.
Okay, the logistics make sense. The pain is managed, but we need to hit the core of our mission today. We know what PRP is, and we know where it goes. But how does injecting your own blood plasma into this tissue actually translate into increased libido?
To answer that, we really have to look past the marketing terms like liquid gold and examine the actual cellular biology of those platelets. PRP is essentially a highly concentrated delivery system for proteins called growth factors.
Here's where it gets really interesting. Because the sources have a massive alphabet soup of acronyms for these. PDGF, VEGF, FGF, FGF. What do those actually do in the human body?
Let's demystify a couple of the heavy hitters. Take VEGF, for example. That stands for vascular endothelial growth factor. Its specific biological job is to command your body to build brand new blood vessels.
Okay.
Then you have FGF, fibroblast growth factor, which stimulates the cells that produce collagen and structural tissue.
Got it.
When these growth factors are injected into the vaginal and clitoral tissue, they act like a project manager rushing onto a construction site with a megaphone, waking up the dormant local stem cells and forcing them to start rebuilding.
So they're forcing the tissue to regenerate. What does that new tissue physically look like? I mean, what's changing?
It primarily manifests through two critical mechanisms: angiogenesis and neurogenesis. Angiogenesis is that creation of new micro blood vessels driven by VEGF.
And more blood vessels means?
Vastly improved blood flow to the area. This allows for healthier, thicker tissue, better engorgement during arousal, and it restores the gland's ability to produce natural lubrication.
Wow. And neurogenesis, that sounds like nerve growth.
It is exactly that. It's the sprouting and regeneration of new nerve endings in the clitoral corpus cavernosum and the vaginal wall. This leads directly to heightened physical sensitivity and physical responsiveness.
Let's connect this cellular science directly back to your libido. Can this simple injection increase your desire? Based on the mechanism you just described, the O-shot isn't artificially creating desire in your brain.
No, not at all. It does not cross the blood-brain barrier. It has zero direct effect on your neurotransmitters.
But it fixes the parking brake. By using angiogenesis to thicken the vaginal walls and restore lubrication, you're repairing the micro tears from menopause and completely eliminating the physical friction and pain of intercourse.
Exactly.
And by using neurogenesis to increase clitoral sensitivity, you're ensuring the physical act is intensely pleasurable.
That is the fundamental mechanism of action. When you know, physically, that intimacy will result in pleasure rather than severe pain, the psychological block on your libido lifts. The anxiety and dread just evaporate.
That makes total sense.
The body's natural desire is allowed to flourish again, simply because the physical capacity for pleasure has been restored.
There was an anonymized patient story in one of the clinic marketing brochures that really hammered this home for me. It was about a postmenopausal woman who hadn't experienced painless intimacy in nearly a decade.
A decade? That's awful.
Right. She didn't need a brain pill to make her want her partner. She just needed her body to stop hurting when they tried. Once the tissue was repaired, her libido naturally returned. It's just so logical.
It is highly logical, and the sources point out that this localized tissue regeneration has profound secondary benefits too. Because the injections fortify the tissue of the anterior vaginal wall, they inadvertently strengthen the periurethral sling.
Yay, what's the periurethral sling?
It's the tissue that physically supports the urethra.
Oh, meaning it treats urinary incontinence.
Yes, specifically mild to moderate stress urinary incontinence. That is the frustrating leakage many women experience when coughing, laughing, or exercising.
I know so many people who deal with that.
Exactly. Additionally, the powerful anti-inflammatory properties of the growth factors provide massive relief for patients suffering from lichen sclerosis, basically regenerating the damaged skin in ways traditional steroid creams often fail to achieve.
I have to admit, the cellular biology is incredibly compelling. It sounds like a silver bullet for women's health. And if you read the marketing materials from the aesthetic clinics, they certainly price it like a silver bullet.
They definitely do.
Looking at the UK sources, these treatments range from 950 to 1,600 pounds per session.
It's a massive investment.
So what does this all mean? Is this proven science or just highly effective marketing? Like, are these aesthetic clinics just capitalizing on a vulnerable demographic with deep pockets?
That is the necessary reality check. If you look at the peer-reviewed data, the landscape is complicated.
Okay, complicated how?
On one hand, the clinical trials we possess are overwhelmingly positive. Studies utilizing objective measurements, like the Vaginal Health Index, which physically measures elasticity, fluid volume, and epithelial integrity, show marked, undeniable improvements after PRP therapy.
The actual physical tissue is better.
Right. And the Female Sexual Function Index, which is a standardized questionnaire measuring arousal and satisfaction, also shows dramatic spikes.
Yet, despite those results, the International Journal of Innovative Technologies and Social Science still classifies these modalities as experimental. Why the hesitation from the broader medical establishment if the results are right there?
Well, the hesitation stems from the hierarchy of medical evidence. To declare a treatment the absolute gold standard, the medical community demands large-scale, multi-year, randomized, double-blind, sham-controlled trials.
Okay.
If we connect this to the bigger picture, for the O-shot, that massive volume of data simply does not exist.
Why not? If it works, why aren't pharmaceutical companies funding massive trials to get full FDA backing?
Because of the nature of the treatment itself. PRP is an autologous biologic. It is your own blood. You cannot patent a patient's own plasma.
Oh, wow.
Therefore, massive pharmaceutical companies have zero financial incentive to spend hundreds of millions of dollars on clinical trials for a product they can never patent, package, and sell in a pharmacy.
That is a staggering loophole. So the FDA regulates the centrifuge machine that spins the blood, but they don't regulate the actual procedure of re-injecting it.
Precisely. This leaves PRP in a medical gray area where the clinical application by private doctors is vastly outpacing the academic clinical trials.
Which means, as a patient, managing your expectations is absolutely vital. If you drop 1,500 pounds on this, you need to know this isn't a magical overnight fix.
Far from it. While some clinics market rapid results, the biological reality of angiogenesis is that building new blood vessels takes time. Patients typically need 3 to 4 weeks to feel the full effects of the tissue regeneration.
And it isn't a permanent structural change, right?
No, the body continues to age. The regenerative effects of the growth factors typically last between 12 and 18 months before a maintenance injection is required.
Good to know.
Furthermore, the ASPS clinical guidelines offer a very sobering caveat. If a woman has never achieved an orgasm in her entire life, due to complex psychological or deeply ingrained neurological reasons, the O-shot is highly unlikely to be a cure.
Because it's just fixing the tissue.
Right. It restores and enhances existing physiological function. It does not map entirely new psychological pathways.
Which perfectly explains why our sources rarely show the O-shot being used in a vacuum. The top practitioners seem to view it as just one instrument in a much broader orchestra. They call it the holistic toolkit, and the tool most frequently paired with PRP is the energy-based device.
Yes, we're talking about radiofrequency treatments like Thermiva or fractional lasers such as CO2 and ERYE lasers applied directly to the vaginal tissue.
I struggled with this concept while reading the sources. We just spent 20 minutes talking about healing the tissue, and now you're telling me doctors are taking high-powered lasers to purposefully burn and injure the inside of the vagina. How does that make any sense?
It sounds counterintuitive, but it relies on the principle of controlled thermal injury. The laser doesn't obliterate the tissue. It creates microscopic columns of heat damage deep within the vaginal mucosa.
Okay, but why injure it at all?
Because injury forces the body to react. The heat causes the existing lax collagen fibers to immediately contract and tighten. More importantly, it triggers a massive inflammatory healing response, commanding the body to lay down thick, brand-new collagen over the next several weeks.
So if you pair that laser injury with the O-shot, it's essentially a controlled demolition. The laser acts like the wrecking ball, breaking down the old, stiff atrophy tissue, and then the PRP acts as the elite construction crew, rushing into the demolition site with fresh blood vessels and nerve endings to build a much stronger, highly sensitive foundation.
That is a brilliant way to visualize it. The laser preps the environment, and the PRP provides the concentrated biological fuel to optimize the rebuild.
I do want to make one crucial distinction before we wrap up, because the terminology in the aesthetic clinic sources can be incredibly confusing. They constantly mention the O-shot right next to something called the G-shot. They sound like the same thing, but they're entirely different mechanisms, right?
They are completely different. As we've detailed, the O-shot uses your own plasma to biologically regenerate the cellular tissue. The G-shot, however, uses hyaluronic acid, or HA.
Like filler.
Exactly.
Yeah.
That is the exact same synthetic dermal filler used by dermatologists to plump up lips or cheeks.
So it's not healing anything, it's just a filler. How does that help with intimacy?
The G-shot is purely volumetric. The practitioner injects the filler into the anterior vaginal wall to physically plump up and increase the prominence of the G-spot area. By creating a physical bulge, it significantly increases the physical friction and contact against that specific area during intercourse.
which theoretically makes stimulation much easier to achieve,
Right.
but it only lasts 3 to 5 months before the body naturally dissolves the filler, and it doesn't build new blood vessels. It's a mechanical fix, not a biological one.
Correct. And we must continually reiterate that for patients experiencing a pure systemic hormonal crash, where the engine is simply out of gas due to menopause, traditional hormone replacement therapy remains a vital first-line defense.
But for the millions of women who cannot take estrogen, these non-hormonal tools are an absolute lifeline. So, to synthesize this entire deep dive and answer our core question, the O-shot is a fascinating biologically sound application of the body's own healing mechanisms. It does not magically manufacture libido in your brain.
But it aggressively and effectively rebuilds the physical hardware.
Exactly. By using your own growth factors to increase nerve sensitivity, restore natural lubrication, and eliminate the pain of intercourse, it entirely removes the physical roadblocks. It fixes the mechanics of intimacy, which creates the safe, pleasurable environment necessary for a woman's natural libido to finally return.
The most vital takeaway from all of this literature is the validation it offers. Female sexual dysfunction is incredibly common. The loss of sensation, the dryness, the chronic pain, it's real, it's biological, and most importantly, it is treatable.
You aren't alone.
Right. Whether a patient utilizes traditional HRT, controlled laser demolition, or PRP therapy, suffering in silence and accepting a compromised sex life is no longer a medical necessity.
It is about taking the parking brake off and getting your quality of life back. But as we close this out, there was one paragraph in the plastic surgery key source that really stopped me in my tracks. It takes everything we just discussed and flips it on its head.
It really does force us to look at the future of this technology. We have spent this entire discussion framing these tools as a way to heal dysfunction, a way to get women who are suffering back to a baseline of normal.
But as regenerative medicine continues to rapidly advance, we are gaining the unprecedented ability to directly alter and enhance our neurovascular pleasure centers. We are crossing a very distinct line from healing dysfunction into the realm of optimizing pleasure.
This raises an important question, right? In the very near future, who gets to decide when a woman's sexual function is good enough? If medical science can reliably engineer more intense, more frequent orgasms and limitless physical arousal on demand through cellular regeneration, how will that fundamentally change society's definition of a normal sex life?
Will the baseline of human expectation shift entirely? It's wild to think about where the mechanics of intimacy are headed in the next decade.
Well, thank you so much for joining us on this deep dive into the source material. Keep questioning, keep learning, and keep exploring.